Hello students, here I am back with a new topic. Welcome to my channel, Medical Courses Made Easy. I am your Dr. Chandrashekar. Today I am going to make you feel that what you know till now, a concept of upper motor neuron lesion and lower motor neuron lesion was wrong. Because you were thinking that there is one upper motor neuron and one motor neuron lesion. Because till today you were thinking that there is only one upper motor neuron and one lower motor neuron, isn't it? And the lesion causes some signs and symptoms, and most of you would have just by-hearted and written or remembered based on some assumption. And this topic is important from first year to final year, because most of the times you are going to elicit an important response called as Babinski sign, and what happens to muscle bulk in upper motor neuron and lower motor neuron lesion will not be taught in your normal theory classes. So I'm sure after this explanation of what I'm going to today give you, you'll be so feel comfortable that today I understood what is upper motor neuron and what is lower motor neuron, and why there is difference in the signs and symptoms in case if there is any lesion in these neurons. As I told earlier, that you are thinking that there's one upper motor neuron and one lower motor neuron, and the lesion causes certain sets of signs and symptoms. But as I promised you that I'm going to prove you wrong, in fact, there are two upper motor neuron and two lower motor neuron, and if there's any lesion and this neuron separately, you're going to get a different level of signs and symptoms that you can elicit so easily and in simple way. And as I told you that after this session, you will just close your eyes and you can able to tell the difference between these two as simple as possible. Let's move on. Just I want your attention maybe for some 10 minutes to 15 minutes. Listen to this. You'll never forget in your life, even if anybody asks in your dream, you're going to tell the difference between the lesion of upper motor neuron and the lower motor neuron. We'll move. We'll start. Welcome to my channel, Medical Courses Made Easy. I'm your Dr. Chandrashekar. Subject Physiology. So you may get in the examination, maybe first year or even in the final year, the difference between the upper motor neuron lesion and lower motor neuron lesion. Discuss the reasons for signs and symptoms. Mention few tests to distinguish between them. You always land up in confusion, isn't it? How to distinguish between them. Sometimes you intermix up and write in the examination and come out and just suffer. I wrote something wrong. Or they may ask you directly as for 5 marks question, difference between the upper motor neuron and lower motor neuron lesion. So first we'll throw a light on these two neurons, okay? The upper and lower motor neurons forms two neuron circuit. The upper motor neuron originate in the cerebral cortex and travel down to the brainstem and spinal cord, okay? And the lower motor neurons begins in the brainstem and spinal cord and go on to innervate the muscles and glands throughout the body. This is the general sentence. Just we'll have a look of the diagram. You can see here, the green one what you're seeing represents the upper motor neuron and the blue one represents the lower motor neuron. So till today you are knowing only this difference, that there is only one upper motor neuron, and somewhere if lesion happens here, you may get some signs and symptoms, and there's one lower motor neuron, and if there is any lesion somewhere here, you're going to get other set of symptoms, isn't it, or signs. But it is not true, because the upper motor neuron is afferent neuron of the central nervous system, which is responsible for the initiation of the voluntary movement, for maintaining muscle tone, for support of the body against gravity, and regulation of posture. This is a general sentence. Whereas The lower motor neuron is the efferent neuron of the peripheral nervous system that connects the central nervous system with the muscles to be innervated or perform function of impulse received from the upper motor neuron. Means what are the upper motor neuron initiate the impulse, the lower motor neuron is the one who is following and again giving information to upper motor neuron that what you told the information, I have done that, right? This is the basic difference. But if you see in this case, as I already told you that I'm going to prove you wrong that there are one upper motor and one lower motor neuron. In fact, it is false. There are two upper motor neuron and two lower motor neuron. Now, what you're seeing here, okay, this is the motor cortex, and what you see here, this is called as corticobulbar tract, and this is one upper motor neuron. So you can label it as upper motor neuron 1. And from the cerebral cortex, which is coming to spinal cord, becomes one more upper motor neuron that is also called as corticospinal tract. So that is upper motor neuron we have. First one is corticobulbar tract and one more is corticospinal tract. So there are two upper motor neuron. Understood? Come to lower motor neuron. You can see from the central nervous system and from the brain stem, the cranial nerves forms the lower motor neuron that is coming from the brain stem. This is lower motor neuron number 1, and here what you get the spinal nerve. This is lower motor neuron number 2. So if you see this explanation, upper motor neuron, which is shown in the red font, corticobulbar tract that ends at the cranial nerve nuclei, and corticospinal tract that is coming to spinal cord. Whereas the lower motor neuron starts from the cranial nerve nuclei, and from there you get cranial nerves. You can see your numbers. Cranial nerve 5, trigeminal nerve that's going for muscles of mastication. Cranial nerve 7, facial nerve, muscles for expression. I am showing this in green. I'll tell you why I shown in this green. Then third one, together called as nucleus ambiguous. In that we have cranial number 9, glossopharyngeal, is going to tongue and pharynx. Cranial nerve vagus, that secretes acetylcholine. Cranial number 10. Cranial component of the spinal accessory nerve, this is cranial number 11. Supplies muscles of pharynx, larynx, vocal cord, palate, uvula. It's for speech, articulation, deglutition. Cranial number 12, hypoglossal nerve, that supplies the muscles of the tongue. This all is coming for the lower motor neuron of the brain stem. And if you come to the lower motor neuron from the spinal cord, we have here anterior gray horn of the spinal cord, that is going to neuromuscular junction and goes to the skeletal muscle for its contraction. Right? Now we'll see what happens if there is lesion. Now before that, I want to tell you one thing here. Remember, whenever I tell upper motor neuron lesion, the lesion can be somewhere here or somewhere here, right? This is for upper motor neuron lesion. And if I tell the lesion of lower motor neuron, the lesion will be somewhere here or somewhere here, right? So suppose if there is somewhere lesion here, this is not intact up here, but this may be intact. And you have seen the function of these nerves. So please go and study the function of cranial nerves. So if there is any lesion here, you are going to get the lower motor neuron lesion, the signs and symptoms related to these nerves. Understood? That means in the lesion of either upper motor neuron of the corticobulbar tract or the lower motor neuron of the cranial nerves, you're going to get the signs and symptoms related to these cranial nerves. So I just shown this in the green here because today I'm going to deal only in terms of skeletal muscles. Because if you come here for this vagus nerve, isn't it? That is not a voluntary control. It comes for involuntary control, isn't it? But today I'm not going to touch that. I'm going to just deal with the voluntary control mechanism related to skeletal muscles. But only I'm going to discuss about some facial palsy. That's why I will just throw a light on facial palsy, what happens in the upper and lower motor neuron. That's why I'm just showing in the green color here. Okay. Now let's move on. If there is any lesion, what we are going to get the signs and symptoms. Now first we'll start with the upper motor neuron lesion. Now where the lesion would have occurred here, upper motor neuron, the lesion would have occurred here, isn't it? That means you may get the lesion in the cortico-bulbar tract. I told you upper motor neuron lesion, isn't it? That is upper motor neuron 1. Or you may get lesion in the corticospinal tract, upper motor neuron 2, isn't it? So this is what is going for your cranial nerves, and this is going for neuromuscular junction. Now if there is any lesion, as I told you, in the lower motor neuron, you may get lesion somewhere here, isn't it? From the brainstem, the cranial nerve nucleus, from there the cranial nerves. So you may get the lesion here, or you may get lesion here, that is in your spinal nerves. The lower motor neuron you have 2 here, isn't it? Now if you summarize and see, from the cerebral cortex, we have a descending tract, pyramidal tract, premotor, primary motor, and supplementary motor area. From there, there's a descending tract, goes to corona radiata, capsule, midbrain, pons, pyramidal decussation goes to opposite side, spinal cord. So this becomes one upper motor neuron, and here we have cortico-bulbar tract. This is one more upper motor neuron. So we label this as upper motor neuron number 1, and this we label as upper motor neuron number 2. So this is cortico-bulbar tract, and this is the corticospinal tract. Whereas from the cranial nerve nuclei, we have cranial nerves that forms lower motor neuron 1. So we have told so many cranial nerve nucleus here and cranial nerves we told here, isn't it? 10, 9 and all we told here, isn't it? Whereas lower motor number 2 we told here, it is from the spinal nerves. It is from the anterior gray horn to axons, from there to neuromuscular junction to skeletal muscle. It is needed for skeletal muscle contraction. So we have upper motor neuron 1, upper motor neuron 2. This is called as cortico-bulbar tract, and this is called as corticospinal tract. Lower motor neuron 1, that forms all the cranial nerves, what I just mentioned in the previous slide, and lower motor number 2, that is your spinal nerves, right? Okay, now we'll see what about the lesion. Before that, we'll just throw a light on few factors. Now we'll see why the upper motor neuron lesion occurs, the causes, or what is the cause for lower motor neuron lesion. Okay, the cause for the upper motor neuron lesion may be stroke, cerebrovascular accidents. When the blood flow to that particular nerve is stopped, the nerve may die. Demyelinating diseases like multiple sclerosis, vitamin B12 deficiency, that is needed for the nerve function. There is one more condition, amyotrophic lateral sclerosis, that I'm not going to throw a light on this, but it's going to affect the nerves there. That's what you just remember for the time being. Lower motor neuron causes may be, the lesion may be at the cell body, maybe the viral infection like polio. Lesion may be at the axon level, maybe intervertebral disc prolapse, Hodgkin syndrome, diabetes neuropathy, and etc. Lesion may be also at the axon terminal, maybe because of the botulinum toxin and like upper motor neuron lesion. There may be a cause for this also, amyotrophic lateral sclerosis. So this can affect both upper motor neuron and lower motor neuron. And if this occurs, what will be the symptom that we'll see at last, right? Now, before we go, what happens in the lesion, we'll see what is happening normally in the muscles. If I talk in terms of muscle mass, the thickness, the bulk of muscle, what's happening with these two neurons? If I talk in terms of muscle strength, that is ability to contract, what happens when there is functioning of these two neurons? Now, if you see here, this is a diagrammatic representation of what I'm showing here. Now, if you see, this is the upper motor neuron, and if you think this is the corticospinal tract, this is upper motor neuron number 2. I'm talking only about upper motor neuron number 2, not 1. 1 is cortico-bulbar tract. I'm talking about corticospinal tract, okay, which is coming to spinal cord. From there, it's coming to anterior gray horn. From there, we have spinal nerves, and if there is any stimulus from this upper motor neuron from the corticospinal tract, from the cerebral cortex, that is going to stimulate the spinal nerves, and spinal nerves is going to release the neurotransmitter called as acetylcholine. Now, if you think this black box as the skeletal muscle, the acetylcholine is going to act on NM receptor that is present on the skeletal muscle. So, because of the depolarization, the sodium gets influxed and that generates action potential, causes muscle contraction and increases the strength of the muscle. This is physiological. On the other hand, the same acetylcholine is going to induce transcription factor inside the muscle. That's going to help in the synthesis of muscle protein, and that is the reason for increasing the muscle mass. This is what usually they will not tell in the theory classes, that acetylcholine is also needed for increasing the muscle bulk and strength. This is what always puts you in confusion. Understood? Most probably in the theory classes, they are going to talk only related to this muscle contraction, but they will not throw light on the muscle protein synthesis and muscle mass. There you may land up in confusion. Now we'll see how it affects when there is a lesion. Okay, we'll see later. You see here. Suppose if there is lesion in the upper motor neuron, that is in the corticospinal tract. Now what is happening here? This spinal nerve is not getting stimulated, right? When this is not stimulated, what happens? Acetylcholine is not released. When acetylcholine is not released, the NM receptor is not stimulated. There is no sodium influx, decrease in action potential, decrease in the muscle contraction, decrease in the muscle strength, right? On the other hand, there is reduced transcription factors, decrease in the muscle protein synthesis. That's why there is decrease in the muscle mass. The bulk also gets reduced. So this is what's happening in the upper motor neuron lesion. So we got one difference. In upper motor neuron lesion, there is decrease in the muscle strength and decrease in the muscle mass. Okay, we'll go to next. In case if there is lower motor neuron lesion, there is lesion in the spinal nerves, but this is intact. The corticospinal tract is intact, but there is lesion in the lower motor neuron. What is happening here? Same thing. This is not affected. The NM receptor is not stimulated. Sodium influx is not there. Decrease in action potential, decrease the muscle contraction. Same thing happens here also. Non-induction of the transcription factors, decrease in the muscle protein synthesis, and decrease in the muscle mass. That means in both the cases, there is decrease in the muscle strength, decrease in the muscle mass, and decrease in the muscle bulk, right? But if you compare, in case of upper motor neuron lesion, the muscle mass decreases only by 15 to 20%, but in case of lower motor neuron lesion, the decrease in muscle mass is by 70 to 80%. In both the case, both are decreased, but the percentage is less decrease here, more decrease here. And the atrophy, what you term in upper motor neuron lesion, that is called as disuse atrophy. Disuse atrophy. But in case of lower motor neuron lesion, it is called as degenerative atrophy. Remember this. In case of upper motor neuron, it is disuse atrophy. In case of lower motor neuron, it is called as degenerative atrophy, because here there is no initiation of the impulse at all. Disuse, but muscle is still getting atrophied. That's why it's called as disuse atrophy. Whereas in this case, even though there is a voluntary initiation, but this nerve has got degenerated. There is no sense of acetylcholine at all here. That's why it becomes degenerative atrophy. So the difference in both the case, muscle mass is reduced, less reduction here, more reduction here. This is disuse atrophy and this is degenerative atrophy. Now we'll talk in terms of fasciculation. You would have heard lots of time fasciculation. What is fasciculation means? It is visible, involuntary, pathological muscle contraction. Similar to, you get some muscle twitch around your near your eyelid or shoulder without your knowledge, the muscle is shaking, and the skin, you can just visibly see the skin getting shaken, isn't it? This is seen only in the lower motor neural lesion, not in the upper motor neural lesion. We'll see why. Suppose if you are going to take the fasciculation in terms of graphical representation, that is called as muscle fibrillation, and the graph is termed as electromyogram. Now what is happening here? Now we talk only in terms of lower motor neural lesion. That's seen, I told you, the fasciculation is seen only in the lower motor neural lesion, not in the upper motor neural lesion. What is happening here? Now you see here, now if there is a lesion here in the lower motor neural lesion, especially spinal nerves, so there is no stimulation on release of acetylcholine. That's what we already know this. That's why there is no stimulation of neuromuscular junction, that is NM receptor, and no action potential and muscle waves. This already we know. But what is happening here? As there is reduced stimulation of the transcription factors for the receptor, and your muscle will start thinking, why there is no NM receptor? It thinks like that. Why there is no action potential? So it starts producing more and more NM receptors and starts sending towards the periphery, towards this muscle here. So already acetylcholine is not there, but it's sending more and more NM receptors, and the muscle will get hypersensitization. Now for any mechanical stimulus, it starts responding, it becomes more sensitive, and there is sudden influx of sodium because of the increased sensitivity. Because of this, the muscle will start showing the fasciculation. This is because of the hypersensitiveness, because more and more NM receptors will push towards the periphery for the depolarization, but acetylcholine is not there, but still it responds because of the hypersensitivity, where sodium starts coming inside and show muscle fasciculation. So if you visibly see this fasciculation, that's what we term fasciculation, and if you're going to elicit by the graph, it is called as muscle fibrillation. Muscle fibrillation. This you are going to see only in the lower motor neural lesion, but not in the upper motor neural lesion, because in upper motor lesion this still is intact. In lower motor neural lesion, this is intact. That's why the muscle will start producing more and more NM receptors towards the periphery and start responding to the sodium influx due to mechanical stimulation. So fasciculation is present in the lower motor neural lesion, but not in the upper motor lesion. So we got the difference. You can see here more and more upregulation of the receptors, increased sensitivity, and because of the mechanical stimulus, the sodium will start getting influx, and you get muscle fasciculation. That is seen only in the lower motor neuron lesion, but not in the upper motor neuron lesion. Right? We got the difference. So muscle fasciculation, upper motor neuron lesion, no. Lower motor neuron lesion, yes. Right? We'll move to the next one. Now we'll talk in terms of muscle tone. The tone is what? The tension in the relaxed muscle. Your muscle will try to retain the tone even when it is relaxed. It is called as muscle tone. So we'll talk in terms of this imaginary diagram, what I'm just showing you here. You see, this is the CNS and this is your spinal cord. You just see like this. So we start from here. Now this level is cerebral cortex, corona radiata, ventral capsule, midbrain, pons, medulla. Okay, process here. Now you're seeing here the crossing over of fibers to opposite side. Can you see this? This is the corticospinal tract, right? Now this, what you're seeing is called as medullary reticulospinal nuclei. This is the medullary reticulospinal nuclei. This is what I just mentioning in this slide as first time. I didn't told you in detail because it plays an important role in the muscle tone, right? Now we also have one more fibers which is coming here. Can you see this? From the medullary reticulospinal nuclei, we got one more nerve fiber is coming here. Now they are getting fused here at this anterograde horn. Okay. Now, if you initiate an impulse from the cerebral cortex, because it's voluntary, so here you can either initiate plus or you may not initiate, it's minus. That's why I put plus or minus here. On the contrary, alternatively, this medullary reticulospinal nuclei also gets stimulated when you get initiating impulse. So this is here, it is positive, it gets stimulated, but this is inhibiting here. Remember this. Whenever from here you stimulate this, this will inhibit, and that's why this balance here. So whenever you stimulate here voluntarily, at that time there is stimulation of extrafusal fibers that's going to alpha motor neuron, and also stimulates intrafusal fibers that's going to gamma motor neuron. From there you get reflex through type 1A and type 2A fibers back here to inhibit. So if you stimulate here, it inhibits here, and this becomes your reflex arc whenever you stimulate here. And remember, always I told you, when this gets stimulated, alternatively the medullary reticular nucleus spinal also gets stimulated, but in turn inhibits. This is what usually happens. In case if there is any lesion here at this level, upper motor neuron lesion, then what happens? You are going to stimulate here, for example. But previously what we told, it used to come and inhibit here. Because it is got a lesion here, it become opposite, it become positive. So what you initiated is also positive, and what, because of the lesion coming, the impulse is also positive. It becomes more positive here. So at that time what happens? Extrafusal fibers, alpha motor neuron stimulation, intrafusal fibers, gamma motor neuron stimulation, and instead of inhibiting here, because it was stimulated, it becomes overstimulated, hyperstimulated. So that's why it becomes hypersensitive, and there is a high stretch reflex, spasm. It has become spasm, and the muscle will not function. That's why it leads to spastic paralysis, become very stiff in the upper motor neuron lesion. Hope you got the point. If there is no lesion, it would have inhibited. Because there is lesion, it is stimulating. So both are stimulating, and it becomes hypersensitive and hyperreflexia, increased stretch reflex, and it leads to spastic paralysis. Whereas if you damage the lower motor neuron, in this case, suppose, so this is intact, this is also intact. Actually, it would have gone like a physiological, but as there is a lesion in this lower motor neuron, either in the extrafusal fibers that is supplied by alpha motor neuron or in the gamma motor neuron, the positive what you saw here, it becomes negative. When this is negative, this already is negative, the whole thing is lost. There is no stretch reflex at all. The muscle will become flabby, weaken, and this is called as paralysis. The specific paralysis is called as flaccid paralysis. It's become looser. That is seen in the lower motor neuron lesion. So why there is spasticity in the upper motor neuron lesion? That is because of the lesion is here. There is no inhibition. It becomes stimulation. Why there is flaccid paralysis in the lower motor neuron lesion? Because the lesion at the lower level. So there is no stretch reflex at all. That means here it is over stretch reflex. Here there is no stretch reflex. That's the difference between the upper motor neuron and lower motor neuron lesions. I hope the point is clear for you now. Now if you see the causes and what is happening here, here it is hypertonia. The muscle tone is increased. Hypotonia, muscle tone is decreased. Hyperreflexia, the reflex, stretch reflex become more. Hyporeflexia in the lower motor neuron lesion. Hyperspasticity, because the spasticity is called velocity dependent, and resistance occurs at flexion. And the important thing is there is no tremors here. As you see, you're going to see in case of Parkinson's. In Parkinson there was a tremor, but here there is no tremor. The term is called as here spastic paralysis. Here marked muscle weakness. Here also muscle weakness is there, but it is relatively less. Muscle bulk also relatively less. But here mass, that is marked muscle weakness and much decrease in the muscle bulk. The phenomenon what we are going to use it here is called as clasp knife phenomenon, where resistance to flexion of arm initially followed by loss of resistance, like a clasp knife. When you open the clasp knife, initially there is a resistance, then it slowly opens. That's what you want to see in this upper motor neural lesion. That is because of the spasticity, what you're going to see is called velocity dependent. Now, in terms of rigidity, if you speak, rigidity is velocity independent and resistance occurs both at flexion and extension. Here, resistance is offered only on the extension. We are going to open it, isn't it? But in this case, rigidity, the resistance is offered both on the flexion and extension. Seen in case of disease like Parkinson's, including tremors is there in Parkinson, but you are not going to see in this upper motor neuron lesion type. And in that case, it is also called as lead pipe and cogwheel rigidity, because it is going to offer the resistance at every instances. That's what it calls cogwheel rigidity and lead pipe. That's not going to see in case of upper motor neuron lesion. In upper motor neuron lesion, it is clasp knife rigidity. I think hope you have seen this knife where you open it, initial resistance, then slowly it opens. That's what you're going to see in this case of upper motor neuron lesion. Understood? So if you talk in terms of Babinski sign, very importantly asked in the theory paper or in the Viva or in the bedside Viva for first year also and final year. So what is this Babinski sign? Now before that, we will just see what is happening here. You have to know about the anatomical terms. Plantar and dorsiflexion. What is plantar flexors? When plantar flexors are stimulated along with the foot, all the toe of the leg curves inwards and faces ground. So it was like this. When you stimulate, it faces here to the ground. This is called plantar flexion. And dorsiflexor, what? When the dorsiflexor is stimulated along with the floor, all the toe of the leg faces upwards. This faces the roof. So this is called as plantar flexion. And this is called as dorsiflexion, isn't it? Now, how it's going to relate with this upper motor neuron and lower motor neuron lesion? We just have a look of them. In general, plantar flexors dominate over dorsiflexors. What is the meaning of this? Whenever I just take a sharp object and try to scratch this here on the sole, usually your toe or the sole is going to curve downwards, inwards, towards the floor. That is what usually happens, overcoming the dorsiflexors. That is normalcy. Your toes is going to curve and faces the ground when I'm going to scratch under the sole. That's what usually happens. Now I just curve like this to the sole, and the sensory reflex gone to the spinal cord, and you got the motor reflex, so you are facing the floor. That is plantar flexion. So we are going to use the knee hammer, the sharp at the side to do like this. This is what usually you're going to do in your practical examination or in the bedside. So normally muscle stimulator generally stimulate plantar flexors. Toe got curved towards ground as plantar flexors dominate over the dorsiflexors. This is what usually happens. Now what is happening here? When you do this, the corticospinal tract is going to initiate the impulse, and usually the stimulation of dorsiflexors. Whenever that happens, if you do this voluntarily, the toe should face upwards and towards roof. In case if you're going to stimulate the corticospinal tract, then what happens? The dorsiflexor should get stimulated and your toe should face like a fanning and face towards the roof. That's what usually happens whenever there's a reflex, isn't it? But as I told you initially, that in general, plantar flexors always dominate over the dorsiflexors. That's what happens. Means whenever you initiate the impulse, it is going to dominate over the corticospinal tract, and still the toe is curved towards the floor, downwards. That's why plantar flexion. But when you do this, as I told you, the plantar flexors dominates over dorsiflex. But in case if you see in corticospinal tract, what is happening here? This stimulation causes inhibition, that is of motor neurons dorsiflexors and stimulation of plantar flexors. Whenever this happens, when you do that, there is stimulation of the plantar flexors and inhibition of the dorsiflexors. That's why your toe will curve downwards and faces towards the ground, and that is called as Babinski sign negative. Then what is Babinski sign positive? Suppose if there is any upper motor neuron lesion, then what happens? There is already stimulation of the plantar flexors, and instead of inhibiting this, previously we thought it was inhibiting, isn't it? So instead of inhibiting here, it becomes stimulation. If there is any lesion, it becomes opposite. So here there is a dominant action of the dorsiflexors over plantar flexors. So what happens? Instead of the toe curving towards inside and the sole facing down, it becomes opposite. The big toe moves laterally and fanning out of the other toes, and there is dorsiflexion. So in case of corticospinal tract lesion, this activation of the dorsiflexors which dominate over the plantar flexors, and the big toe dorsiflexors and other toe fans out, and this is called as Babinski sign positive, that is seen in the upper motor neuron lesion. There is pathological. So Babinski sign is also positive in the newborn babies less than 1 year or normal, and that is positive because babies lacks the myelination less than 1 year. So Babinski sign is positive only in 2 instances. Either there is upper motor neuron lesion or in the children less than 1 year. After 1 year also, if the baby has Babinski sign positive, then it is pathological. That indicates there is a lesion in the upper motor neuron lesion, isn't it? Whereas if you see the Babinski sign in terms of the lower motor neuron lesion, so as there is no reflex at all, there is no question for Babinski sign, isn't it? It should be negative only because there is no reflex at all here. So whatever may be the neuron intact in the upper motor neuron, as there is damage to the lower motor neuron, the reflex does not arise at all. Hence, Babinski sign will be negative. So this is what the basic difference. Got it? There is other 2 factors here called as pronator drift. That is, you just make the patient to hold the hand in front of his body like this and tap on the pronator. So there is a pronation of the forearm and with little downwards deviation of the hand. That is called pronator drift. That is seen in the upper motor neuron lesion. And also Hoffman sign. If you flick the middle finger like this, the index and thumb finger opposites each other. If you do like this, just do like this to the patient. This index and thumb finger will oppose each other. That's what you're going to see in case of upper motor neuron lesion, and that's not seen in the lower motor neuron lesion. These also 2 factors you can write in the differences. So if you overall summarize and see, please let me know what happens in the upper motor neuron, lower motor neuron lesion. Mass, strength, tone, deep tendon reflex, fasciculation, fibrillation, atrophy, Babinski sign, pronator drift, and Hoffman sign. Okay. We'll see the difference. Muscle mass, 15-20% decrease in upper motor neuron lesion and 70-80% in. Agreed? Decrease, right. Paralysis, here it is spastic paralysis. Already we told there's hyperreflexia and hypertonia, isn't it? Here it is flaccid paralysis because there is no reflex at all. Tone, here is hypertonia, it's increase, here decrease, hypotonia. Deep tendon reflex, when you try to elicit the reflex, because it is exaggerated, hyperreflexia, here no reflex, so hyperreflexia. Fasciculation, over reflex, we told here. Fasciculation, in this case what is happening, it is absent because, as I told you, there's nothing relation with the sodium influx here, but here it is present because of the hypersensitivity of the receptors to the sodium. Fibrillation, when this is absent, this should be absent. So same thing, if this is present, this should be present here. Atrophy, because voluntarily you are not going to use that. That's what it calls disuse atrophy. In this case, even though there is a voluntary stimulation, but you can't use that muscle because of the degeneration in the spinal nerves. That's what it calls degenerative atrophy. And Babinski sign, pronator drift, and Hoffman sign is present here, but the same is absent in this case. Hope you have understood this concept as simple as possible. And if you are having any doubt, again go back and see this presentation. And if still you have any doubt, you can just go to the description box, take my details and contact me. If you like this presentation, I request you to subscribe this channel, spread to as many as friends and your colleagues, and let me know the feedback. So until then, for the next time, here Dr. Chandrashekar signing off from this class. Take care. Bye.